Hello and welcome to the discussion today on a heart issue that is affecting millions of Indians in today's time. I'm Richa Jain Kalra, and today's focus is on heart valve treatment. In the past decade, heart valve diseases have assumed critical importance, leading to severe complications and high mortality rates. India's heart care scene is now transforming with lesser invasive technology that we are discussing today with a panel of some very eminent doctors. I would like to welcome our panel of doctors today. I have with me Dr. Dilip Kumar, Senior Interventional Cardiologist and Structural Heart Expert at Manipal Hospital, EM Bypass, Kolkata. I also have with me Dr. Rakesh Kumar Jaswal, Director and Head, Department of Cardiology, Director at Cardiac Cath Lab, Fortis Hospital, Mohali. And I also have with me Dr. Rajneesh Kapoor, Chairman, Interventional Cardiology at the Medanta Heart Institute, Gurgaon. A very warm welcome to you all, sir.
Thank you.
Thank you.
Thank you.
So I want to start with you, Dr. Rajneesh. One of the common disorders of the heart today is related to the heart valves. Could you help us understand more about these heart valves disorders, which are noticed more these days?
Yeah, so this is a very important stuff as regards to heart functioning is concerned. Now, there are four valves in the heart, and all the valves are very important when once we talk of a smooth heart functioning. So these heart valves make the blood flow in a unidirectional manner. Unidirectional means it opens and closes with every heartbeat. Once it opens, it moves forward. It should not come back the minute the heart starts contracting or relaxing. It should only flow in one direction. So whenever any disease of these valves happen, it may shrink, the valves may shrink, or the leakage may start happening in the valves. Now, both shrinkage as well as leakage is detrimental to the heart functioning. That can lead to lots of symptoms, and majority of these patients with these valve disorders, they start complaining of breathing distress to start with, initially on exertion, then on rest, then with a minimal effort, they can have these breathing discomforts. So this is very important that valves, they have to function in a normal manner with a normal opening and closure to have the best heart functioning. If they are not, it is going to create lots of problems in terms of dynamics of the heart functioning, and people will have lots of symptoms. So mitral valve, aortic valve are the left-sided valves. Now there are diseases like rheumatic heart disease, which actually start affecting from the childhood. One infection which happens in the throat that leads to some interaction with the valve tissue, and that leads to rheumatic heart disease where the mitral valve can go narrow. I mean, shrinkage can happen and leakage can happen in mitral valve. Similarly, aortic valve can also be involved. Then there are diseases of the elderly, degenerative aortic valve disease. Now, what happens? Because of the repeated stress on the heart valve over the years and years, the valve tissue leaflets, they take a lot of stress and they start thickening in response to that stress. That thickening and then subsequent calcium deposition on the aortic valve can lead to aortic stenosis. Now, this is also very dreaded. Now, beyond 65 years of age in India, almost 5 to 10% of the population will be affected by degenerative aortic stenosis, which is a disease of elderly. And this can be so dreaded that it can cause a cardiac arrest, sudden cardiac deaths. So we have to pick and choose and the valve disease at an earlier stage so that it hasn't affected the heart badly, so that we can actually give a full treatment of this valve disorders. So
Right.
aortic valve, mitral valve, and then there are certain disorders which affect the right-sided valves also. Pulmonic stenosis is a right-sided valve disease, which is again a congenital disease. The valve disorders can be congenital, rheumatic heart disease, or diseases of elderly. And one important additional point is a bicuspid aortic valve, where again aortic valve is congenitally malformed in such a manner that it tends to give a disease of aortic valve at a younger age. Again, narrowing or leakage both can happen.
Right. So we learned about the valvular stenosis from Dr. Rajneesh. I want to bring in Dr. Dilip here and talk about this aortic valve stenosis. So what does this mean in a common man's language, and what are its causes?
Yeah, Thanks, Richa. So aortic stenosis, as Dr. Rajneesh just pointed out, the valvular diseases, the valve can shrink and the valve can leak. So aortic stenosis essentially is a stenosis of the valve, means the valve, the orifice area has, reduced, it has come down. So if the patient has a aortic valve area which is less than 1 centimeter square, we call it as critical aortic stenosis or severe aortic stenosis. And the reasons are basically we see in our situation, in our population, we used to get a lot of rheumatic valvular heart disease earlier, but nowadays we see mostly degenerative aortic valve disease that causes aortic stenosis. And when it comes to symptoms, these valve, if they get stenosed, the main blood pool which goes out from the heart, it goes through aortic valve to the body. So if the valve has narrowed down, so the entire cardiac output becomes less to the body, and every organ of the body gets compromised. And the patient develops symptoms in form of shortness of breath, in form of angina. They can have a syncopal episodes. So when it comes to valvular pathology of aortic valve aortic stenosis, essentially degenerative aortic valve disease and rheumatic heart disorders, and sometimes there's a congenital problem can happen. The patient, they are born with two cusps rather than three cusps, and this is the commonest congenital anomaly for heart diseases, and it happens in 1% of the normal population. And by the time they become 50 years, 60 years of their age, these valves starts degenerating faster. The calcium deposition becomes more and more faster, and valves get stenosed. So these are the reasons of aortic stenosis, and this is how they present. I narrated those symptoms, and then we can these patients require therapy in form of valve replacements.
Right. So let's dig a little deeper on AV stenosis with Dr. Jaswal. Dr. Jaswal, how common is this in today's times? And could you reflect more on the symptoms if a common person can make it out?
See, aortic stenosis, the incidence goes on increasing with the advancing age. If you take a population of around 50 to 59 years of age, about 0.2% of the population will be having aortic stenosis. The decade next, that means 60 to 69, it is 1.3%, 70 to 79, it is 3.9%, and in octogenarians, the percentage is as high as 9.8%. So with every passing decade, the incidence goes on doubling. So if I put it roughly, in an Indian population of 1.35 billion, 75 years plus people, about 3.4% is the incidence in them. So that means about 27 lakh people uh, are above 75. And among these patients, people, about 7 lakh individuals have severe aortic stenosis. And out of them, nearly 2.8 lakh people, they are candidates for TAVI or transaortic valve replacement. So there is a huge, unmet demand for this procedure. And as far as symptoms are concerned, the common symptoms are angina, which presents as exertional chest pain or feeling of compression or heaviness in the chest, or sometimes constriction kind of feeling, which mostly starts from the center of the heart, of the chest, and it travels on both the sides, more so on the left side than on the right side. It can present as choking of the throat, or even lower jaw pain, or pain anywhere from lower jaw to umbilicus in front and neck. So this is a symptom called exertional angina. And then these patients can have sudden transient loss of consciousness, which is called syncope. Third symptom is exertional fatigue, palpitations, and dyspnea on exertion. And once the disease is advanced, then people start getting short of breath even at rest. They may get feeling of shortness of breath on lying down, what we call as orthopnea, or sometimes they get up at the middle of night gasping for breath, which is called paroxysmal nocturnal dyspnea. And once it is further advanced, then patients tend to have even pedal edema. So these are the common symptoms, but we must notice one important point that in aortic stenosis, the symptoms come very late. It may progress silently. And once the symptoms appear, that is the time when the disease is already progressed and the outcomes are not that good. After angina appears, the average lifespan of the patient is considered to be just 5 years.
Oh,
Similarly, once syncope comes, then the average lifespan is considered to be 3 years. And people who are grossly symptomatic, they have 50% survival only at 2 years. And event-free survival, I mean, without any discomfort, I mean, major discomfort or
mm,
any major adverse event, only
okay.
30 to 50% of these people, they survive at 2 years. So it's a very serious condition once it becomes symptomatic. That is the
Right.
purpose of today's webinar, that we make people aware that how they can recognize the symptoms in early stages and pick up the disease before it gets too late.
Definitely, sir. That is the whole purpose of spreading more awareness through this show. I'd now like to focus upon the available treatments for aortic valve stenosis. Dr. Dilip, would you like to reflect more on this?
Yeah, so essentially, when the aortic stenosis becomes severe and the patient is symptomatic, as Dr. Jaswal told, once the patient becomes symptomatic, the clock starts ticking. So we need to intervene in these situations, and the only definitive therapy for aortic stenosis severe symptomatic patients is to replace the valve. So valve replacement is the way to go, and we can replace the valve by two methods. One is through surgical aortic valve replacement. When the patient is, put to for general anesthesia, we do a median sternotomy. We take the patient on heart-lung bypass, and then we we take out the previous valve and implant a new valve. So these are done by cardiac surgeons, and this is called surgical aortic valve replacement. The second method is transcatheter aortic valve replacement, where we don't require to put the patient on general anesthesia. We can do it under mild conscious sedation. We get through in the body with a small hole through the groin, and we cross the valve with a wire, and then we deploy the valve inside the diseased valve. So what happens? The new valve starts functioning, and the previous diseased valve is getting sandwiched between the newer valve and the aortic valve. So, and it can be done within an hour or so. Patients usually can go within 24 to 48 hours after the procedure. And if the procedure was uneventful, so then 24, 48 hours timeline is, appropriate. And some of the patients may require, additional day of hospital stay. So these two therapies are there for aortic stenosis patients. And
Right.
when we talk about TAVR, essentially these are for those patients who are more than 65 years, because these are bioprosthetic valves and they can degenerate, and the lifespan of these valves around 8 to 10 years, which after that patient may require another valve. So it depends on the life expectancy of the patient, at what age the patient is presented to us, and also the surgical risk of this patient, the operating risk when we are going for a surgical aortic valve replacement. And there is also patient's choice, what patient requires. So for the
Right.
particular age group to 65 to 75, both surgical aortic valve and transcatheter aortic valve, they are the methods with which we can do the valve replacement. So the surgical risk, patient choice, life expectancy of the patient, we decide the therapy.
Right. Dr. Rajneesh, when it comes to heart valves, open heart surgery has been one of the common options. Now, Dr. Dilip just told us about TAVR. How is TAVR a better option as compared to open heart surgery?
Yes. So, previous decade or so, we have been doing this now TAVR, which is a transcatheter aortic valve replacement. And Dilip has already gone through lots of advantages which TAVR has over and above the surgical aortic valve replacement. So now surgical aortic valve replacement, the patient has to have his chest open by a surgical method, and patient has to be on a heart-lung machine. So these two things itself produce lots of morbidity. this leads to lots of blood loss, which ultimately, even if the surgery is successful and patient has come out of hospital, the patient continues to complain of lot of weakness and fatigue for almost 1 or 2 months. So this is the reason, because surgery is like a ordeal, and first, the length of the stay after surgery or during surgery is 8 to 10 days in the hospital. Then the post-operative phase is not always very smooth. They have lots of pain over the stitches, and then the blood loss, anemias, fatigue, weakness, infections, some issues with the wound. All these are the issues related to surgical aortic valve replacement. Now, once we started doing this TAVR, we felt that it is a highly patient-friendly procedure. We are doing TAVR from a small incision in the groin, and then there is no anesthesia given. We do almost in a conscious state now. Patients remain in a conscious state or minimally sedated, and they are practically awake. And we do the TAVR. It's 1 hour, 1.5 hour procedure, and no blood loss, no anesthesia, no weakness, no fatigue after the procedure. Only in few patients, which is 2 to 3% patients, may require a pacemaker after the TAVR, and that was true even with the surgical AVR also. So besides that, 97% of the patients, they can get a discharge in 2 or 3 days from the hospital. They are absolutely mobile next day. They are out of ICU next day. Since we are not doing any surgical incisions, there is no chance of infection, which is highly prevalent post-surgical AVR. So there are many advantages. Now, only caveat which one has to keep in mind, that TAVR is not a therapy for younger patients. Because the durability of the valve in TAVR, where we use this bioprosthetic valve, the durability is maximally around 8 to 10 years. So if we do the TAVR in 55-year-old patient with aortic stenosis, that is not justified. So normally the age limit from where the TAVR starts getting popular and becomes a modality of choice in patients of aortic stenosis is usually 70 years. But yes, there is a 65 to 70-year population with aortic stenosis, which if the patient is having some higher risks for surgery, then he's a candidate for TAVR. Or if the patient is absolutely adamant not to undergo surgical AVR, then again we can think of TAVR. But it is not justified to think of TAVR less than 65 years of age unless the surgery is absolutely denied because of comorbidities, because of the durability factor. So this one has to keep in mind. It's a beautiful therapy in patients, in elderly patients more than 70, and in a gray zone patients between 65 to 70 years. It's a beautiful therapy, and patient is usually very happy after the procedure as if nothing has happened. He goes home, he enjoys with his family very next day. I mean, third day he's back home and all totally mobile, enjoying all parts. So this is the beauty of this therapy, and I think it's going to go further, more and more utilized as the cost comes down. We have seen this growth in last 10 years. So now practically where we were using 5 years back this TAVR therapy in 3 or 4 patients a month, at Medanta we are almost doing 20-25 TAVRs a month. So the therapy is growing, and it is quite patient friendly and a good therapy in a selected subset of patients.
So, Dr. Kapoor, just a little more on this. So, how is it performed? The patient is awake. They can understand what's happening. It's done digitally. If you can throw more light on that.
Yes. So, what is happening is, like, we do angioplasty. Patient is on a cath table, and we are making some punctures at the femoral artery from where we take the access in the groin. That is under local anesthesia. So patient is not feeling anything there. We keep the patient awake, and we have a stipulated nursing staff on the head side of the patient, which keeps on talking to the patient, keeping him engaged. So patient is awake. We have stopped giving even sedation now. Sedation, we think of in those patients where we feel that patient can be very restless or can move a lot during the procedure, then we give sedation. Otherwise, patient is totally awake. In local anesthesia, we go with the procedure. We advance the valve from the groin and this is seen on a fluoroscopy. And from that guidance, we have various, pointers we keep that here the valve has to be deployed. These pointers, they guide us. There is no pain which happens to that patient. And once the valve is deployed, the practically his aortic stenosis is treated because the new valve in that TAVR skeleton starts functioning immediately. So
Right.
it gives a relief to the patient immediately after the valve is deployed. Obviously, one careful thing which one has to keep in mind, we are all going gaga about TAVR, but then the important message is it has to be with a good expert centers where expertise is good, where the patients are doing a certain good number of TAVRs a year. Then once the chips are down or any complications happen, so that they know how to come out of it.
Right.
Obviously, whenever we are doing any cardiac procedure, the 5% procedures can be associated with some complications. So those complications matter with expert hands, and I think that is one thing. Now it's also a promising thing that more and more centers are doing more and more volumes. Once the volume picks up, this would happen. This we are expecting. So this is a good promising stuff that more and more experts, operators are now well trained and they can actually give the beautiful outcomes to these patients with a TAVR therapy.
I think you've well explained that how it's done and what is the caveat here. I want to reflect more on the benefits of TAVR. Dr. Jaswal, if you could tell us.
Yeah, as far as benefits are concerned, initially when we started doing TAVR, it was indicated only for those patients who were high risk for surgical aortic valve replacement, what we call as SAVR. So goes without saying that this is much more safe procedure compared to a surgical aortic valve replacement. It is less cumbersome, as just Dr. Rajneesh mentioned, that it's even you don't need even sedation these days, and just like the way we do it in coronary stenting, local anesthesia, get an access to the groin artery, go inside, put a wire across the valve, and then deploy a valve and come out. It's a very simple straight procedure in hands which are frequently doing it, right? So it is highly comfortable for the patient. Patient goes back home within 48, 72 hours in case there is no complication. And in majority of the patients, there is no complication. And fourth, fifth day, patient is doing almost all activities. And by the end of 1 week, he is fit to do his even morning walks as well as, can drive car and do all the activities. So recovery time is very short compared to the surgical valve replacement. It is very comfortable, low risk, and in fact, particularly in our country, we are doing very high risk patients who have a lot of comorbidities and uh, bad ventricle, also poor ventricle. So despite that, we have seen that the outcomes are very good. But at the same time, we should be very cautious in selecting patients for TAVR. As I
Right.
mentioned earlier, also about 40% of all patients of severe aortic stenosis, they are picked up for TAVR, and rests even today going for surgical aortic valve replacement. And the
Right.
selection criteria should be such that there is definite indication. Indication definite means that these are the patients who are above 65 years of age, as already repeatedly mentioned,
Right.
should not be a young person, but we have done in younger people also who
Okay.
were prohibitive surgical risk patients. So surgical aortic valve replacement was not an option in them. And in these patients, we have to plan a lifelong management of aortic valve disease for them.
Right. Sir, also we've seen in elderly patients because of heart valve issues, the quality of life suffers. So what is the level of awareness regarding TAVR in India today?
See, TAVR is relatively new, innovative, cutting edge treatment option, right? And unfortunately, many patients are, or general population, they are not aware of this available therapy. And as we mentioned earlier, also that's the objective of today's webinar, that we make people, more and more people aware, because once they are aware, then they'll get the benefit out of it. And I must say that the benefits are immense for those who actually need it. And the impact of untreated elderly patients in our city is also immense. They have very poor quality of life. They cannot enjoy simple things in day-to-day life, like morning walks, maintaining their hobbies, or driving a car, even locally, and go and meet their family members or friends. And gradually, as the disease progresses, these patients, they tend to find it difficult to carry on their day-to-day self-care activities also, and therefore they become more and more dependent upon the caretakers. So, which is a kind of, very poor quality of life. So that is why, it is important that this therapy should be uh, made aware and available
Right.
to the patients. And equally important, as already mentioned, is we must ensure that there are best uh, practices for TAVR. Very high quality, procedures are done, so that we don't unnecessarily land up with complications, one, and we can offer them a long lasting solution. We are sure that, as per literature, up to 10 years, the life of this bioprosthetic valve is there. After that, we might have to look for other options.
Right, sir. So, Dr. Dilip, I want to bring you in. All patients these days look for faster recovery in their illnesses. How can the innovations in heart valves help them?
So you see, we look for a rapid recovery. So no one would like to being hospitalized for more than 1, 2 days, 3 days. If given they want to go home, same day of the procedure. So it all depends on the access side. And when the tower was started, almost 22 French access was required. Now gradually it has come down to 14 French. So something around 2.3, 2.5 millimeter, centimeter hole is being made. And then we, close it through sutures, which are deployed percutaneously. We don't require surgeons to repair the vessel. This is how we have grown, and from 22 French to 14 French. And the next innovation would be coming down on your, access site. So if you bring down the access site to, access hole to 10 French, 8 French, the patient can definitely go home, next day, most of the patients. Also, the type of valves, they can make difference. So we have two kind of TAVR valves at this moment. So one is a balloon expandable valve, and second is self-expandable valves. And these valves basically ensure that we choose the valve properly. And 2/3 of cases, either of the valve variety can be fitting in there. But we have kind of liberty of choosing valve sizes in balloon expandable valves, and especially those who these valves are made in India. So Indian manufacturing valves, they have got different kind of categories of sizes, which can ensure a precise valve size for a particular anatomy where the patient requires. So someone has a 23 annulus, where self-expanding, we take a higher size valve, and we have got very less, valve sizes to choose from. But from Indian makers and Indian manufacturers, we have a valve size, kind of options, which are too precise for a particular patient. So these are the innovations which are coming on the way. And finally, we would require to have a valve which can last longer. So the innovation is also getting on there. So we have some data of 8 to 10 years while these valves are, lasting, but we need to work on the valve durability. If these valves last longer, 15, 20 years, then there will be a one valve for one, lifetime. So this is how the valve, entire the transcatheter aortic valve is evolving.
Okay. Dr. Rajneesh, you talked about that how it is mainly TAVR is mainly suitable for elderly patients. So that is one eligibility. Would you like to tell us about the protocol before TAVR happens?
Yes, so any patient who is symptomatic with critical aortic stenosis beyond the age of 70 is certainly eligible candidate for TAVR. But yeah, again, one important thing which we miss out here, that this is a costly therapy, and still in India, many patients may not be in that zone where they can afford this treatment. So in that scenario, if they can't afford this treatment, still they can go a surgery way uh, if their health is okay, if they can withstand surgery. So that is one thing. So any affording patient more than 70 is with a critical aortic stenosis symptoms is eligible candidate for TAVR. Similarly, as I mentioned before, even beyond 65, if he has some morbidity which makes him at a higher risk of surgery, still he becomes a eligible candidate for TAVR. Now, once we pick and choose a patient who's a candidate for TAVR, uh, he has to go through a certain important tests and investigations. Besides, having a full checkup with the blood tests, obviously we have to know his all the organ functions, the kidney functions, liver functions, everything. The two major and important investigations, which is absolutely a prerequisite, is a echocardiogram. If transesophageal echocardiogram is done, that is even better, and a CT scan. So CT scan is a very, very important investigation before planning and before methodically where you are actually planning all the steps of TAVR. We need to know the CT dimensions of the aortic annulus where we have to place a valve. You can well imagine, this is a very small zone where now we are going percutaneously with no surgery with a valve there. Now, if somehow somebody has not done analysis methodically, the things may go wrong. It has to be a proper and precise dimensions of that area that we should know to have a smooth and a successful outcome of TAVR. Because in the vicinity, there are coronary arteries which are supplying blood to the heart, which are very close to that area. We
Right.
need to know the heights of those coronary arteries from the aortic valve, the dimensions of aortic valve, the area of the aortic annulus, and there are many other structures, sinus of Valsalva's. So this is very important to have a precise dimensions in that area so that we can pick and choose the right size of the valve. And if there are some red flags, like coronary arteries are very, very close to the annulus, they are in the proximity to the annulus, then what thing can go wrong, that coronary artery occlusions can happen with TAVR. So we
Right.
have to be prepared and circumventing all these problems while planning. So CT scan and a echo, and preferably a transesophageal echo, these two things are must to plan a good successful outcome of a TAVR. And again, I said it's a team approach. Uh, it's not a one-person job, it's a two-person job usually, and even if a good paramedical staff and a good nursing staff is there along with in the OT room, a guy who's from anesthesia, cardiac anesthesia, he is also very important. A radiologist doing the CT cuts. CT is also not like a routine CT, it's a specialized CT with a very thinner cuts so that
Right.
we can have those dimensions precise. So this is some of the important information one has to have to actually plan the TAVR very successfully.
Right. Dr. Jaswal, for people who might be interested in TAVR after seeing this discussion, what would you like to tell them? How soon would they be back into their normal life?
Yes, that is very important. I think this is the biggest positive about this method, that people are quickly back to their jobs. So, as I mentioned earlier, also, after TAVR, about 48 to 72 hours later, we discharge these patients. And then, fourth day, fifth day, they're able to carry on all the activities. And by the end of 1 week, they can do virtually all activities, including, their morning walks and driving the car locally, and they feel as good as they would have felt in the absence of disease. So the fast recovery is one of the positives for which this therapy has now been, tested even in low risk patients.
Okay.
Though we are quite skeptical, in our country to do TAVR in very low risk cases, but then it has been tested and proven to be effective even in low risk cases because of these advantages and early mobilization and early recovery and patient's ability to go back to his job quickly.
Right, sir. So, Dr. Dilip, again, though we've spoken about how long it may work, but how do you see this developing and evolving? How long will the valve last? Does it also depend on one's lifestyle, or there's a definite period for it?
Yeah, so I already said that, and we all have been, given this idea that the average valve, bioprosthetic valve, they last 8 to 10 years. But some of these valves can last even a little longer. Some can, last even a little shorter. But this is the average lifespan of these bioprosthetic valves. And we would like to have valves which can last longer, but we have to plan the patient's procedure according to the present lifespan of the valves and expected life expectancy of the patient. Suppose someone who is 80 years, what's the life expectancy? How many years he's going to live? So it's basically 10 years. Then you straightway go with a transcatheter aortic valve and put there, and you relax that this will do good for his lifetime. Suppose a patient who is 70 years or 65 years, say, so the average life expectancy will be around, the further life expected will be 15, 20 years from there. And then we have to plan that either we give a surgical aortic valve first, which can last 10 years, and then we put a transcatheter aortic valve, because going for a TAVR after a surgical aortic valve is easier job. Suppose you put a TAVR first and then the patient requires surgical aortic valve, then again the patient will be, it will carry the good, it will do the job. You look at the life expectancy and you have done two valves for the patient. But here comes some challenges when we talk about a surgical aortic valve after a TAVR. So it depends on patient choice. So if we give choice to the patient, see, we both have options. Now you decide amongst the surgical aortic valve and transcatheter aortic valve. But someone who has a prohibitive risk for surgery, say he's 65, his life expectancy is only 10 years. Sorry, life expectancy is 15, 20 years, but he's so sick, he has so bad lung, surgical, surgery will be very high risk. Then we choose again a transcatheter aortic valve. So this is how we choose. We have a limited, lifespan of these valves. So we have to decide which valve to be given to which patient according to these three, priorities and these three
Right, sir.
characteristics.
Dr. Kapoor, if you could briefly tell us, how many valve replacements happen in India annually, and how many institutions today are equipped to do this in India?
I can give you approximate data. So I think initially, once we started 7, 8 years back, so there were hardly 10, 15 centers, but the number of centers who are doing TAVR are growing. So I think it should be close to 150, 200 centers who are doing TAVR now in India. Although still with the volume centers would still be around 30, 40 centers in India who are doing more than 10 TAVRs a month. But it is growing. And similarly, the number of operators are also growing. Uh, you know, I don't have a real idea that how many operators would be there, but I think
Okay.
it should be around 1,000 operators who have done TAVR or who are doing who are in a stage of who have starting to do TAVR who have done few, but who are they're in the learning mode. So
Right.
total could be around 1,000. But number of valves definitely are increasing. The TAVR procedures initially was less than 1,000, but now we are crossing a 2,000 TAVRs a year total. And I think we next year we may double this number. So
Okay.
next year it may be 4,000 TAVRs in a year. So I think it is growing, but India is a very cost-effective market. It's not easy to put any procedure which it costs around 15-17 lakhs to a patient, and patient will come up and decide in a minute. It's not
Right.
easy, you know. There are only 1% of the or 2% of the population who can actually decide to come in this bracket. So otherwise, why the numbers are increasing? There are some reimbursement schemes which have now starting uh, to allow reimbursements in a TAVR space. So that is where numbers are growing. But still, I don't think we can grow at a pace where the Western countries have grown, because the Western countries are not a cost-effective market. It's absolutely, they are fully insured. The patient doesn't have to think, and the doctor, they are also not thinking about the finances. They can plan the best procedure, and they can use any consumable on the patient, because
Right.
that is not coming from the patient's pocket directly. But India, we need to think many things. You know, we have
Yeah,
to be very.
India has different dynamics, and definitely cost-effective treatments are preferred. So, Dr. Dilip, coming to you next, out of the total valve replacements happening in India annually, how many do you think are done via TAVR or TAVI?
So you see, Dr. Kapoor just told the numbers of tower which is happening in India. So this is something, the ratio is must be 1:20. So if 20 surgical aortic valve, one transcatheter aortic valve is happening in India. So we are far less than what Western world is doing. We are doing around 2,000 to 2,500 valves per year,
Right.
transcatheter aortic valve, but we have potential to do so many. So we require something like lakhs of TAVRs should be we should be performing annually in this country. So I think the
Right.
awareness needs to be more, and numbers of operators have really become, the pool is becoming larger and larger, efficiency is becoming much better, infrastructure is getting better, but this TAVR versus surgical aortic valve ratio needs to be shortened and narrowed.
I think one thing that needs to be addressed, as Dr. Kapoor just said, about the financial considerations. Dr. Jaswal, would you like to share your opinion that how it can be made, affordable? What are your views on that?
One thing is that many government schemes are now giving cashless, treatment of TAVR, like, ex-servicemen contributing contributory health scheme, central government health scheme, state government schemes, and many insurances are also now providing, cashless services for these patients who require TAVR. Certain companies also have evolved an effective loan program, and therefore they address these financial help to the patients. And these commendable initiatives have made the therapy more accessible as well as affordable for the people, thereby enriching lives of these patients. So, and
Right.
another thing I would think is that once the awareness comes, then the affordability level of out-of-pocket payments will also improve with passage of
Right.
time.
Right.
But we,
And
I think, need to do more supportive, financially supportive, decisions should be taken by the government as well as at our own levels to help these patients out.
right. So, last question to Dr. Dilip. How is the Indian medical device industry geared up in latest developments of TAVR therapy? If you could briefly touch upon this.
Yeah, so briefly and very happily, I must tell you that Indian device industry, especially for TAVR, is really doing great. In India, in 2012, Tower came and MNCs brought Tower to India, but with the advent of Indian manufacturers chipping in, we have now valve coming at cost of 40% than the MNC company valves, and this has triggered a lot of kind of ease to us and acceptance in the general population. And these valves are very effective. They allow us to choose sizes, as I spoke a little while back. And these devices are also CE approved. So these devices are also doing great in European market. So this is something like a very successful story so far, and we are looking forward for an even better journey.
That's great. A big thanks to all our panelist doctors for coming on the show and sharing some very valuable aspects of this revolutionary technology for the heart valve treatment. Our effort is to empower our viewers and our patients about this cutting edge technology for making informed decisions in the interest of their health. I hope this session